Good morning, everyone. Thank you, Dr. Zarrinpar and Dr. Eswaran for those great talks. We have a lot of questions in the chat, so I'm just going to get going here. So this is for you, Dr. Eswaran. How does a diagnosis of liver cancer affect transplant candidacy? How to think about transplant priority and wait time for patients with liver cancer?
Yeah, so some patients that have liver cancer are a liver transplant candidate, and that's based on the size and the number of the tumor and making sure that it isn't elsewhere throughout the body. And so when we talk about whether or not a patient is a candidate, then we have to also make sure that they have no other medical problems that might make a liver transplant unsafe. And so a patient that has an evaluation for liver transplant, and if the evaluation looks good and the tumor is within criteria for a liver transplant based on the size and number, then they would be placed on the liver transplant list. And then there's a bit of a wait time. There's usually treatment for the liver cancer while the patient is waiting for a liver transplant, and that might be performed by the interventional radiologist. So a TACE or a tear might happen, and that's really to control the tumor while someone's waiting for a liver transplant. And then there's a waiting period to make sure that the tumor doesn't come back, because really it's important to make sure if we do a liver transplant, then it's going to be a cure. And so there is a bit of a waiting time when we talk about listing for transplant. And then after liver transplant, we look at the tumor from the liver that's been removed, and then we can get an idea of how likely that tumor might recur after transplant, which is usually pretty low.
And that's a great segue into one of the other questions, which was a question about the risk of liver cancer recurrence after transplant. So maybe walking us through how you think about that.
Mm-hmm. So the rate of recurrence after transplant is based on the size of the tumor before transplant. But also when we look at the explant, the liver that is removed, the one with the liver cancer, we look at it under the microscope, and there are certain features on that explant that will tell us what the likelihood is. So we compare what we thought the size and the number was before transplant with what we're seeing in the explant. And there are certain scores, certain models that are used, like the morale score and the retreat score, that your doctors would know how to calculate to give you an idea of what the likelihood of recurrence is.
Excellent, excellent. And this is a question for Dr. Zarrinpar. How often is fluorescence used? Is this a common thing across centers, and are there any side effects to using it intraoperatively?
So it's not common across centers. There are a handful of places that use it routinely. I use it all the time. And the reason for that is twofold. One is it gives you extra information that you're not going to get. Two, it's easy, meaning that I always see my patients before operating on them, a few days before. It's a good chance to really kind of talk about things, answer any remaining questions. They come in on the same day as they're seeing their anesthesiologist already, so it's not like an extra trip. And it allows us to give an IV injection of the indocyanine green to them that day. Basically I can do that, anywhere between 1 and up to 14 days before, because what happens is that the fluorescent dye actually gets taken up by the liver, but the abnormal parts of the liver actually hold on to the dye, and that's what helps fluoresce in the operating room. What are the side effects? Really, it's pretty minimal. This is a dye that's been used since, 60, 70 years. I've actually checked my own liver function multiple times with it. It doesn't feel like anything. It's not like it makes you green or your pee green or anything like that either. So the only reason not to use it is theoretically, if you have an iodine allergy, you're more likely to have an allergic reaction to the drug. So we don't give it to patients who have an iodine allergy, but that's about it. I think the nice thing with it is that again, it's just additional information. There's really very little sort of risks to it.
Okay, excellent. One question that came in is advice around, 1, second opinions, and 2, what if someone on your team is not the right fit for you? Can you get someone else to replace them? So maybe start with that one, Dr. Eswaran, and then we can talk about second opinions after that.
Yeah, that's a great question. And it's not uncommon. Sometimes you don't have a connection with an individual and don't feel like it's the right fit. So within an institution, there's usually multiple providers within that subspecialty. So one option would be to request another individual in that institution. But certainly seeking a second opinion at another institution is perfectly reasonable. And I think all providers should be open to that, and don't feel like that someone is going to be offended or you're going to be in the wrong in that decision. So I think most providers encourage people to seek a second opinion if you want to, and you are certainly free to do so.
I agree. So another question that came through was, is there a better chance for a more favorable outcome if you opt to undergo surgery, for example, resection or transplant? Or do you usually see better outcomes with systemic therapies like we were talking about yesterday? So maybe Dr. Zarrinpar, you wanted to take this one.
Yeah, so I think when it comes to liver cancer, the goal is to cut it all out, whether it's transplantation or cutting part of the liver out. We kind of went over how to make that decision. Most reason for that is that, for transplantation, the liver disease is the problem. We need to get rid of the liver disease. There are cases in which systemic therapy is good, but the response rates are actually not that great. We talk about it being much better than what we used to have. That's true, but it's still not that great. We talk about 5-year survivals after transplantation for liver cancer of 75%. With systemic therapy, it's nowhere near that. So if the option is available, meaning that if the tumor is within criteria and the patient is within criteria for any sort of surgical options, that gives you the best chance. Now, does that mean that, just because you operate on someone, you can't give them systemic therapy later? No, that's not true. And vice versa. If you get systemic therapy and you become within criteria, then you certainly, can have an operation. So I don't necessarily think of this as either or, right? And the same thing with transplantation or getting some sort of local regional therapy. Just because you're getting local regional therapy doesn't mean that you're not going to get later treatment, or just because you're on a transplant pathway doesn't mean that you're not going to have your tumor treated. So this is kind of all hands on deck. All tools on the in the tool belt are going to be used depending on what you're eligible for.
And I think that just really speaks to Dr. Eswaran's graphic where she had the patient in the center and all the disciplines and the picture of everyone in the room. Like, we're continually assessing where a patient's at and what's the right therapy for them at the right moment. And yes, usually we're thinking that transplant is a cure for liver cancer. So we're really aiming for that when that's possible. So more questions here are, what is the acceptable alpha-fetoprotein range for listing and continued listing? And can we talk a little bit about how blood type affects transplant?
Sure. So there is who is it for?
Yeah, that's for you.
Go for it.
Go for it.
So so the alpha-fetoprotein is a protein marker in the blood that detects that can detect liver cancer. So if it's very high, that suggests maybe a more advanced stage of liver cancer. So for liver transplant, it needs to be below 500. And if it is high and the tumor is treated, then that number can come down. But there is a requirement that it is lower than 500. And then
how about the effect of blood type and transplant?
So you get listed according to your blood type. If you're an O or an A blood type, then you basically have to get an O or an A donor. If you're a B or an AB, you generally, if your MELD is lower, you get a B or an AB, but as your MELD climbs higher, you'll have access to, just because A, B, and B are less likely to get a matched blood type donor. You will get access to the, if you're a B, you'll get access to the O's, and if you're an AB, you'll get access to an A, B, or an O. But yes, I mean, I think as long as the blood types are compatible, then getting the liver is acceptable. Now, that said, in living donor situations, and this is not something that we do a lot in the United States, but in living donor situations, there are protocols for mismatched blood type donation. I think that there are not many transplant centers in the US, but the transplant centers in Korea and China who are who don't have the deceased donor options as much as we do here. They do much more of that mismatched donation. The complications are higher just because of the mismatch, but it can be done.
So I think one of the take-home points is asking your physicians, if you're on the transplant list, what blood type am I? What is the MELD score of transplant in my location, and how long am I expected to wait? These are kind of questions that we're all very happy to answer on an individual basis. Probably one of the final questions we have time for here is, at what point in someone's care would you recommend them to consider a clinical trial? Is it when a patient is out of other potential options or earlier in their treatment plan? Dr. Eswaran?
It's a great question, and I think some of this was covered yesterday in the first day of this conference. And I think it was highlighted that there's no acceptable or unacceptable, I should say, there's no unacceptable time to consider a clinical trial. It can be early, and I think your team should know how to access clinical trials. And even if you're newly diagnosed, it's definitely appropriate to ask at that time what clinical trials are available for my stage of cancer, knowing my other medical conditions. And then the team can help you find an access to those.
Yeah, absolutely. So, clinical trial just basically means we think these two things are at least conceptually almost equivalent, and we need to do a trial to make sure to see if one is better than the other. And whether it's a surgical clinical trial or a medical clinical trial or any kind of clinical trial, just depends on where, it just depends on what the trial is planning on studying. And so, anywhere along the line, you could be eligible for a clinical trial. And the other thing to consider is that just because it's a clinical trial doesn't necessarily mean that we have no idea what one is going to do versus the other. There, any kind of clinical trial that's been vetted by, a system, it has to go through an investigational review board, has to go through, the bigger clinical trials have to actually, be registered and gone through through the FDA. So that multiple people have looked at it and said, there is equipoise, right? So that we don't really know whether one is much better than the other. And so we have to do the trial. And somewhere along the line, if it's obvious that one is better than the other, the clinical trial will actually get stopped. So you're not going to, no one's going to say you need to be on a trial because, we want to, I don't know, we don't know, but because we know one is better than the other, and you could get the terrible one. I think if the trial is available, it's certainly something to consider.
But I will say, Dr. Guy, that you don't always need a clinical trial.
Right.
If you have a transplant or resection as an option, and your doctor and your team think that you're going to have an excellent curative response, then you don't necessarily need to go beyond that. It's always a good question, but it's not always necessary, because we know a good amount about liver cancer and we have so many different options.
And I think that is a really important take-home point too, and I hope people are getting that from this conference, is that there are so many options, and the decisions are really complicated around what is the right option for a person at a given time. And that's why engaging your team and knowing that your team is engaging each other really makes a difference. So if people have questions about clinical trials, yesterday's talks, including Dr. Dennis Zekaran's talk from Stanford and Dr. Tim Grayton's talk from the National Cancer Institute, are things that you can look at via the YouTube page for the American Liver Foundation. So we are at time, and I just wanted to thank both Dr. Zarrinpar and Dr. Eswaran for joining us this morning and giving us a great outline as to how to be thinking about treatments and our medical teams. And I will pass it over to Ivory. Thank you.